For those that have not met me yet, I am Dr. Sara Mulholland, Vice President of Expansion here at Full Spectrum. And tonight's Journal Club, we're going to be looking at research related to trauma-informed care in ABA. This is an area that's been getting more attention lately, but in ABA circles, it's not really talked about a whole lot. So wanted to make sure that we address it. It was even difficult to find journal articles specifically addressing trauma-informed care connected to ABA. Here's the sign-in code. It's going to be a little different today as far as the CEU, the way we do the CEU for analysts and those who are accruing that credit. Make sure you jot down this sign-in code because you are going to need to put the sign-in and sign-out codes in first, and then it auto-populates the presentation, the title and everything. So sign-in code 4625. So as far as the task list and ethics code items tonight, in the analyst task list, we're looking at B3, which is define and provide examples of respondent and operant conditioning. B8, define and provide examples of unconditioned, conditioned, and generalized reinforcers and punishers. E3, responsibility and practice. H3, recommend intervention goals and strategies based on such factors as client preferences, supporting environments, risks, constraints, and social validity. H9, collaborate with others who support and or provide services to clients. For the RBT task list, we have B2, assist with individualized assessment procedures. C3, use contingencies of reinforcement. C10, use generalization and maintenance procedures. And F5, maintain client dignity. Areas of the ethics code that will be addressed: 107, which is cultural responsiveness and diversity. 2.01, providing effective treatment. 2.15, minimizing risk of behavior change interventions. And 3.12, advocating for appropriate services. All right, so the first article we're going to look at is the Rajaraman et al. I'm really hoping I pronounced his name right. This one was called Toward Trauma-Informed Applications of Behavior Analysis. So a bit of an overview of what this article aimed to address. Looked at trauma-informed care, will be abbreviated TIC on slides. So trauma-informed care is gaining traction rapidly in many treatment modalities. Also looked at what is trauma-informed care. It addressed ABA circles and how they historically have shied away from trauma-related approaches and some of those reasons. Also discussed how avoiding trauma-informed care can affect effectiveness and public perception of ABA. Also discusses historical barriers to using trauma-informed care in ABA and concepts of trauma-informed care that are already present in ABA terminology and applications. Any thoughts before we move on? Any of those questions, specifically why ABA might have avoided talking about trauma-informed care? If anyone has any thoughts, go ahead and put those in the chat and we can kind of look to see if they line up with what the article found. Oh, we have a hand raised. Michelle?
I actually thought I read with this journal article a little bit, and I just find it really interesting about where even before we really get into it, with our field, like how the difference of how with behaviors that everything is so observable, and we don't think about more of the internal thoughts. We don't really talk about that because that's our field is so focused on just more of the of things that we observe rather than what's internal.
Yeah, for sure. It looks like Maria put in the chat that it tends to fall in the more mentalistic category. Yep. I think you guys will be surprised, though, how well we can intertwine it. So first of all, what is trauma-informed care? Before understanding trauma-informed care, we need to understand what is trauma. which sounds simple, but it's not, because this term has had many definitions over time, often relating to perception of events. Many tend to believe the event has to be life-threatening, such as a major car accident, natural disaster, or near-death experience to be considered trauma. So as far as trying to answer the question of what is trauma, generally we tend to look at psychological trauma, and that exposure to an event adversely affects the person's well-being and functioning. While it might be life-threatening, it doesn't have to be considered trauma. It could be one event or multiple events or a set of circumstances that have caused physical and or emotional harm to the person. Generally, will have long-term adverse social, emotional, physical, spiritual, or mental effects. However, long-term doesn't necessarily mean months or even years. It could mean several days. Basically, it means it's affecting them adversely for longer than the duration of the actual event. So it really can be any event or series of events. So as far as actually looking at trauma-informed care, so the concept of trauma-informed care doesn't mean that we are discussing the trauma over and over. That's another common misconception. Trauma-informed care simply means that we acknowledge the presence or history of the trauma and that it might be affecting the clients or their families or stakeholders. It's basically an understanding that allows us to be more person-centered when we're developing our interventions. So we use the understanding of potential trauma history to design interventions and provide accommodations as appropriate for that individual. Actually allows us to increase participation and effective results because we're using interventions that are more informed and therefore more centered towards that particular person or family. So as discussed before a little bit, we're going to delve into this a little more. The ABA tends to have a history of avoiding trauma. Patrick said nothing simple about trauma. That is true. Very true. So as far as the ABA avoidance of trauma, a big part has been the unclear definitions. As we've just talked about and this article discussed, the concept of trauma has never been real cut and dry. There's not a good objective behavior analytic definition of trauma. It's not camera checkable, not something that we can observe all the time. Some traumas, yes, you're able to see that they happened, but not always. It also, as Michelle and Maria mentioned before, tends to be more internal, tends to involve more of what we call the private events, those internal responses. So again, not observable and therefore often overlooked. While ABA over time has become more accepting of private events and acknowledging that they do affect behavior, often they're overlooked when we're trying to look at the whole picture. And history of ABA, a lot of times private events were not really considered. When we're looking at trauma-related behaviors, oftentimes those antecedents are unclear. It could be a historical event that is controlling the current behavior. So we have current contingencies that we're looking at. We're trying to see what happened right before the behavior. When it's trauma-related, you have to go back a little further. So in ABA, we tend to look at the immediate antecedent because that generally makes the most sense. When trauma is involved, the antecedent might be unclear. The person might be responding to stimuli that seems neutral, but they're responding in an unusual fashion. It is common to attempt to find out why that particular stimuli is triggering, but we don't always know that the reason is because a feeling or a memory is connected to that stimuli in some way. Interesting fact that I wanted to throw in here. The human brain and body remembers events longer when a strong emotion was attached to that event. So they experienced some type of strong emotion during that event, whether it be a positive or negative emotion. And that's why trauma can affect people for so long. So an emotional experience could be the antecedent, even though it was long before what you're seeing today. When people talk about trauma, they tend to focus more on feelings and perceptions rather than behavior. So that's another reason that ABA often doesn't really delve into that. because they tend to look again at more that mentalistic aspect. So that can make us feel like trauma-informed care isn't really in the wheelhouse of ABA. Additionally, the usual assessment tools that we use in ABA don't address trauma. They don't look at that history. So a lot of times we don't even know it's there. That goes along with this next point. We often don't know about that trauma history. Either it wasn't shared with us or it wasn't known, or the individual who experienced it is not able to communicate that that happened to them. And also, as a last point here, there's not much literature about using trauma-informed care, at least not literature that is data-driven on these practices and outcomes. So again, that's another reason in ABA, it often hasn't really been looked at. All right, so now we're going to look at how we would apply trauma-informed care in ABA. And again, that's all based on this first article. When we do the next trauma-informed care presentation that's coming up later this month, we're going to delve more into this also beyond just these two articles. So this article talked about 4 commitments and values that are part of trauma-informed care. And those 4 commitments are to acknowledge the presence and impact of trauma, to ensure trust and safety, to promote choice, and to emphasize skill building. When you look at those 4 commitments and values, any of those look a little like ABA? Don't we address traumatic events when getting the history during the assessment? Deborah, some do and some don't. It's not necessarily a common approach that everyone does. We have some basic history. So like if you look at our intake packet, even when you're looking at the overall, like a clinical interview setup, we do talk about, have there been any recent changes that might be affecting them? It doesn't necessarily delve into trauma history though. So that might not be something that they think to bring up in that initial interview if we're not asking directly. As far as some ABA components, what I'm hoping you guys see in here is ensuring trust and safety is very much like pairing, and promoting choice and emphasize skill building are things that we are building into our plans already. So a framework that was proposed by this article for using trauma-informed care in ABA is first to make sure that we are defining these core commitments, these 4, in ABA concepts, that we're conceptualizing it in our ABA terminology so that it makes sense, that it's truly behavior analytic. That we can encourage effective participation in the assessment and treatment related to trauma-informed care goals. So we're taking this into account, that potential history. I keep saying potential because, again, we don't always know. And when you have others, children that you're working with that can't really communicate trauma, you don't always know that it was there. Sometimes it's not until they react in a certain way that you realize something affected them. Okay, Deborah said she believes that the BCBAs that she works with have been doing a great job answering that. That's awesome. I'm glad to hear that that's already showing up in some plans. So I also wanted to note that trauma-informed care is not the same as trauma-specific service. That's a point that was made in this article also. Trauma-specific service is more like counseling. So when we think of trauma-informed care and you think of the more mentalistic aspect, that's more trauma-informed service. That's the counselors that are having them talk about the trauma, process those feelings, and try to move through those. It's more reactive. A trauma occurred, so we're going to treat that specifically. Trauma-informed care is actually more proactive. So it supports the clients and takes measures to make sure that we're not doing something that is re-traumatizing them in any way. It is also taking into account that there may be trauma that we don't know about or that could be easily triggered, and we're taking care to make sure that we're not part of that. So again, looking more at the trauma-informed care in application, that first commitment that we talked about. Acknowledge the presence and impact of trauma. When we're trying to put this in more behavior analytic terms, we can look at conditioned and generalized reinforcers, and punishers. So quick review. A conditioned reinforcer or punisher, it's a stimulus change that increases or decreases the future frequency of the behavior. When it's conditioned, it's been paired with some type of punishment or reinforcement, and therefore has affected the behavior. It also could become generalized to other behaviors or other potential stimuli, especially if it's been paired with multiple reinforcing and punishing consequences. So ABA tends to look at the immediate or visible stimuli, but sometimes there might be an event attached to that stimuli that was the actual conditioning of it as a reinforcer or punisher that might be affecting the magnitude or effect of that on the behavior. So some examples of this would be a raised male voice historically has been paired with some type of abuse for the child. It could be that we have a child who has an aversion to hugs because they have a history of being restrained. It could be someone has a history of falling downstairs leading to significant injury. So now they have some type of reaction around stairs. Also could be aggression leading to seeking escape. Looking at some generalized reinforcers, this is when some of those reinforcers or punishers, those stimuli have become generalized to other areas. So this may be happening when you have a behavior that seems like it has all the functions, but it doesn't necessarily feel automatic either. So ABA tends to tell us if it occurs under all circumstances, more than likely the function is automatic. But in these cases, that doesn't seem to fit. So some examples, someone runs or cowers when anyone talks too loudly, not just a male voice anymore, just anyone barely raises their voice and they run away or they hide. They have aggression in response to any physical contact. It's not just a hug anymore. It's someone barely touched them and they became aggressive. The person who has a history of falling down the stairs now avoids all stairs to the point that it actually inhibits their ability to move around. The one who used aggression to try to escape in the past now uses aggression every time things get difficult. So now they have generalized those responses to multiple areas instead of just the one. So the next commitment of trauma-informed care is ensuring trust and safety. And remember, in ABA, building trust and safety for the clients and families is already part of what we do. It's pairing. When we're pairing with the clients, when we're pairing with the families, we are building a connection. That is building trust and safety. So we're already doing it. One thing I wanted to point out here also is remember that the trauma history might be on the caregivers more than the client. So this is about the whole family, not just the child. I had an example not too long ago that an analyst that I was talking to had been talking to a mother and she reacted in a way that we were like, oh my goodness, where did that come from? Because what the analyst was trying to tell her was not earth-shattering in any way. And my first reaction was, there's trauma there that we don't know about. We just triggered something. So sometimes it's the family. And that doesn't mean we're never going to trigger trauma. It's going to happen, but we have to be able to be informed so that we can work with that. So part of ensuring trust and safety is making sure we're creating that environment that feels safe both physically and emotionally for those involved. It may mean that we're conditioning safety signals. So the article talked about safety signals as basically something that lets the client know things are okay, gives them kind of a break from whatever is stressful at that time. It indicates some type of predictability or the absence of aversive stimuli. So it could be that when they take a break, it's in a certain area that's like a free play area. It could be that we're using a visual schedule so that they know what's coming next. Okay, I finished this task and I get a break. I see that that's coming. It might be that they have somewhere that they feel like is a safe space, so we make sure they have access to that on a regular basis. This also means that we're going to allow modifications to what we're doing based on the child's experiences. We're really going to, and their responses, I apologize. We're really going to want to look at their responses and know when, you know what, they're having a rough day or something that we're doing right now is very triggering for them. So maybe we need to reduce the demands a little bit. Maybe we need to prompt them to take breaks or ask for help a little more. Maybe we just need to move the activity to a different room because something in here is really upsetting them right now. So being able to make those modifications and know that it doesn't always have to be a hard line, we're doing this right now and these steps, and it has to be this way all the time. Knowing that we can make those little modifications to help the child have a better chance at success. It also means that we're not only going to identify warning signals of the escalation or when they're really struggling, but we're also going to respect them by helping to teach them adaptive responses. So not only are we making those modifications when we see it's needed, but we're also helping them learn different ways to cope with whatever that trigger is, which is skill building that we'll be talking about in a moment also. It also means that we're avoiding physical management unless there is no other option to ensure safety at that moment. There are some situations that using physical management may actually make it worse. I actually worked with someone who had some severe self-injury, and I was told by the school that when he was engaging in that behavior, that they didn't put hands on. And honestly, at the time, that made no sense to me. Like, that was so uncomfortable because he could really, really hurt himself. But then I was able to see what they meant. And they had different ways of approaching. They dimmed all the lights. They got people away from him. They gave him space. They made sure to lower their voices. And sure enough, that would help him de-escalate instead of trying to put hands on him or blocking him from hitting himself. And like I said, very, very uncomfortable to watch, but that's about me, right? Not about him. And I had to learn that and accept that. And as I've studied in this area, I've realized that's trauma-informed care. So sometimes that crisis de-escalation is going to involve also some type of reinforcement. That means we might mildly reinforce a behavior that we didn't want to prevent the crisis from escalating to a point of feeling like there's no return before somebody gets hurt. Also means that we're going to minimize escalation as much as possible and know that even if we accidentally or purposely reinforce something in that, we are still teaching them that this behavior escalation doesn't always have to end in crisis. We're letting them know that there is a way out. Remember, safety is always number one. So if we do have to reinforce something we didn't want to in order to keep everybody safe, that is okay. We can always reset later because everyone is still safe. A little bit more about ensuring trust and safety, because this really is a big one. So the article talked about ensuring the families feel safe. So that means we're pairing with the families, the caregivers, the teachers, anyone who is involved with that child also. It means we're showing them empathy. It's not the same as sympathy. Some of you have heard me talk about that before. Empathy is being able to understand where they're coming from. Sympathy is feeling sorry for them. Feeling sorry for them, reinforcing bad behavior because you feel sorry for them is not okay. Empathy is being able to understand where they're coming from, even if the response is not what we're looking for, being able to understand how they got there so that we can help them find different ways of reacting to whatever that situation was. We also need to make sure we're reinforcing the efforts of the family, not always telling them, hey, you didn't do that right, or you need to do this way. Acknowledge the fact that they're trying so that they also are building trust and safety with you. So you're giving them feedback, but you're also inviting them to give you feedback and let you know what they're comfortable with and what they're not, and being able to build on that. So just a reminder here, a primary component of trauma-informed care is ensuring that everyone feels safe throughout the services. That also ties into our ethics in ABA. It's part of the principle of beneficence, making sure that this is benefiting the clients, the families. We're promoting well-being and welfare, which is right out of ethics core principles 1 through 3. Identifying positive and negative impacts and potential conflicts that could be present. That we're treating others with compassion, dignity and respect, and we're always behaving with integrity. Right out of our code again, honest and trustworthy manner. If you're building trust, you are acting trustworthy. So the next commitment of TIC that was discussed was promoting choice. So a foundation of TIC is elements of client choice, control, and autonomy. That means we're also minimizing the risk of re-traumatization, and we're not making them feel powerless. Does that mean that they're controlling the entire session? No, but it means we're giving choices at every opportunity that we can so that they see that they have a role in this and they have options. And again, this is for the caregivers too. Very similar to our principle of shared governance, which means we are involving clients and stakeholders in the decisions we make. Again, ties right back into our ethics. And in general, we're already teaching choice making in ABA. That is a very common goal that you'll see time and time again in treatment plans, being able to make choices, and also interventions that involve allowing them to make choices. So trauma-informed care just means we're capitalizing on the opportunities to be able to do that at every chance that we get. Also, the choices don't always have to be a yes, no. So it's not, do you want to do this, yes or no? That's not what we're always saying. Sometimes it's things related to scheduling. You know, do you want to do writing first or do you want to do reading first? You know, do you want to work on, you know, the communication? Like when we're looking at communication, what are some choices there? You know, ways that they can communicate. It might be how we work on a goal. You know, do you want to practice it? You know, or do you want to sit down and talk about it depending on their functioning level? Might also be when to work. Do you want to start work now or do you want to wait 5 minutes? However, there has been very little research about incorporating choice in your interventions. And I'm wondering how many of you are surprised by that, because I certainly was. We promote choice in so many goals in ABA. And yet they did a study of 141 articles about ABA interventions. Only 6% of them talked about incorporating choice as part of the intervention. Anyone else surprised by that? So there's not that much data on that. Definitely think about that. Another advantage to promoting choice is we might find reinforcers that we didn't think about for the individual. So if we kind of make it a free choice once in a while, what do you want to play with? What do you want to work for? And see what they say. We might find some reinforcers that we wouldn't have thought about. It also promotes independence, which isn't that the overall goal in ABA? Is we're promoting independence as much as possible. A little bit more about promoting choice. It builds in autonomy, not just for the clients, but their families too. Provides a sense of control. Because they're making choices, you're going to have more buy-in and participation because they feel like their opinion matters. It also allows us to challenge those historical experiences and those learning patterns by allowing them to see they don't have to do it the same way over and over. They don't have to have the same traumatic experience over and over. There are options. Some examples I really wanted to bring up here also of potential trauma events, because again, this goes right into our ethics that we're wanting to make sure that we're respecting the experiences of others as well. So some potential trauma history events that could also be affecting caregivers. I just wanted to make sure that we mention these too. Having a controlling partner. So again, remember, trauma isn't always one particular event. Sometimes it's a series of events that have developed behavioral patterns. Domestic violence situations. It could be that family has been shamed by others over and over again, possibly because of the behaviors of their child or their attempts to work with their child. It could be that the family has been turned down time and time again for the necessary resources that they need. Maybe they had some really bad experiences in treatment, whether it be ABA or somewhere else. Maybe the child's been hospitalized over and over because people just couldn't help them. Maybe social services has become involved. Those are things that we need to be able to consider. checking some comments here. Providing choices is so important for increasing independence, for sure. Often research isn't truly applied or geared towards a more controlled environment for research purposes and publication over informational value to practicing providers in behavior analysis. Yeah, sometimes it's not really as direct in what we're doing, that research. That is true. Thank you, Dr. Bellotti. So ethics core principle number 2 says that we acknowledge personal choice in service delivery, that's important by providing clients and stakeholders with needed information to make informed choices about services. So again, comes right into core principles of ethics and ABA as well. So the next commitment in trauma-informed care that was discussed in this article was to emphasize skill building. Again, we're already doing this in some way, shape, or form. We're always working on building skills. So every behavior plan is incorporating this already. Trauma-informed care specifically is going to teach building skills on how to react to those trauma triggers, as well as skills that work for their individual learning patterns. So we're going to provide empowerment to the clients and families for them to realize that their experiences in the past don't dictate their future. They can build ways to combat that and get their own power back. We're going to make sure that we're responding to any trauma-related symptoms and antecedents and teaching them ways that they can respond to those symptoms and antecedents in ways that don't make them feel powerless. We're going to also define and recognize what trauma responses are in behavioral analytic terms so that we can develop those replacement behaviors. And again, that's more on the follow-up session that we're going to have about this. Trauma-informed care approaches for skill building best align with DRA, so differential reinforcement of alternative behaviors, because you need to teach specific alternatives to cope with those trauma-related triggers. So we use DRO in some things also, but when it comes to trauma, we really need to teach very specific responses that they can use instead. So we're teaching self-regulation skills, also known as coping skills, although we know that they don't like that when we put that in plans, so call it self-regulation. The same thing. We're teaching them ways to regulate themselves so they can react in a different way. We're also going to be making sure we're developing functionally equivalent replacements, because those needs that are being met by those maladaptive behaviors are ways that they're responding to trauma to meet a need. Usually it's to feel safe. Usually it's to know what to expect, what's coming next. Those needs will always be there. So make sure that the new behaviors that you're teaching still meet those needs. And remember, apply it to caregivers also. I can't say that enough. So many times I hear people talk about difficult caregivers in the way that they're responding. How many times do we think that it's because the caregivers have some trauma that they're dealing with? They may not even realize it's there. So now we're going to talk about the effect that trauma-informed care can have on ABA as a whole. So as I said before, research, data-driven research on trauma-informed care is minimal. However, the evidence that the trauma experiences happen in this particular client population is very strong. Also want to remind everyone that lack of research does not mean that the approach is harmful or ineffective. Lack of research is just that. We haven't researched it enough yet. In general, trauma-informed care is using proactive approaches that are meant to benefit the client and family. You are not going to cause harm if you are using a trauma-informed care approach, because the whole aspect of this is making sure to avoid causing harm. As we know, there's a lot of negativity about ABA out there historically, and some still subscribe to those negative views. A big one that you hear is that ABA causes trauma. Whether it's valid or not, that view is out there and it is prevalent. So if we're using a trauma-informed care approach, we are directly challenging that view and supporting the experience of those clients and families. As we just talked about, the majority of the foundations of trauma-informed care very easily applied to ABA and translated into behavior analytic terms. So just because the research hasn't necessarily put the two together doesn't mean they don't connect. And just a reminder here that trauma-informed care does not cause harm. In fact, it aims to prevent harm. So what concern could there be in using it? And Deborah says she still hears that view sometimes. I do too, especially online. And thank you, Dr. Bellotti. It's true. A lot of people aren't even aware of their own traumatic histories and how they're experiencing those now. I'm glad it's helpful, Courtney. Thank you. So trauma-informed care is going to help us increase that social acceptance and therefore social validity of ABA as a whole, as a field. Also, by using this, we're expanding the scope of service to populations that maybe before thought that there was no way ABA could help. If we're showing that we're using a trauma-informed care approach, those who maybe were very aversive to even trying it might think about it now. So in summary, using trauma-informed care can help mitigate some of those concerns of public view of ABA. So now we're going to talk about how this article proposed a framework for using trauma-informed care in ABA. I want to point out this is not a drastic change. After we talk about this, you're going to realize that I'm pretty much just saying, do what you already do, but make sure you have that intention to be informed and respectful of individual experiences. So in this framework, we're going to acknowledge known and potential trauma experiences for clients and their families. We're going to create that therapeutic environment that promotes safety and trust. Again, that is pairing. We're going to promote autonomy via choice making. We're going to develop interventions that teach adaptive skills, and we're going to be proactive. So again, do what you do. Just be informed. A little bit more about the framework, so that some examples were given in the article. The first thing they talked about was prioritizing assent. So it's different than informed consent, which is a much bigger thing. Assent is more in the moment. Yes, I want to do this. No, I do not. So clients and families can, quote, opt out by making choices. So there could be times that the kid's like, I don't want to do it. And you allow that. It's okay. However, if you notice that the child is opting out, giving opt-out signals over and over and over again to the same thing, that doesn't mean we need to hit it harder. That means we need to look at what's going on. Is there a aversive stimuli present? Is there a prerequisite skill that they don't have yet? What is going on that they don't want to try this new thing? And then over time, if necessary, so if whatever stimuli we have actively avoided is something that they're going to come across in their life a lot, we can gradually reintroduce it as we build those skills to adapt to it. So that doesn't mean we're avoiding triggers all the time. It means we're avoiding some at first until we can build them the skills to be able to deal with them. We are going to avoid programming that's going to trigger those trauma responses while we work on increasing safety signals. Again, very client-specific, very person-centered. Some of this might be related to known ACEs, those adverse childhood experiences. Again, we'll talk about that more on the 30th when we go into this more. It might mean we're avoiding any type of physical management or even physical prompting, depending on the child. It might mean we avoid all timeout procedures because the child has a history of neglect. And therefore, a timeout procedure is really triggering that. Might also mean that we're building in more non-contingent reinforcement. Maybe we're providing things like break cards, asking for space, building in a lot more breaks because that's what helps that child feel safe. Also means that we are monitoring the client's responses as we go and adjusting our expectations as needed. So again, maybe the opting out, them not wanting to do it over and over and over, means there's a prerequisite skill that they're missing, so they honestly don't know how to do whatever this new skill is. I've had plenty of times that I have set a goal with a client, and then after we start working on it, I realize that, you know what, how can I expect them to do step C when they don't know how to do steps A and B? So we got to back it up and teach those other skills first. It could be that we're giving step-by-step directions very slowly. It could be that we're using visual schedules, or it could be that we're really honing in on those replacement skills first. Remember, the fact that we're avoiding potential trauma triggers at first does not mean we're avoiding it forever. We're teaching them how to deal, and then we can reintroduce that. As Sarah said, trauma-informed care in ABA is compassion over compliance, 100%. So that was it for the first article, which was the longest one of the two, the most in-depth. Any questions before I summarize the next one? And I am being mindful of time, so I'll check for questions as we go too. So the next one was the Hawk and Dracobly, and I'm sure I mispronounced those, but it was called Trauma-Informed Care for Individuals with Intellectual and Developmental Disabilities, from Disparity to Policies for Effective Action. So this particular article looked at trauma-informed practices that historically targeted neurotypical populations. It addressed disparity factors regarding trying to bring those services to persons with intellectual and developmental disabilities or just severe trauma histories in general. Also looked at advocacy in ABA circles, how we can advocate to bring these services to those that we work with, and looked at current tools and methods and how to apply those to the IDDD population in a trauma-informed care approach. So the first disparity it looked at was historical segregation. It's not a secret. People with intellectual and developmental disabilities have been segregated from general population throughout history. A lot of that caused trauma, both directly and indirectly, especially institutionalization. So many, historically, and even some now, have been physically separated from their caregivers, from their loved ones, from society in general, because of the intellectual or developmental disability and how it was affecting their behaviors. In the 1960s, they started the whole deinstitutionalization movement, but they did not have the support they needed. So research showed from 1977 to 2009, the numbers of people who were institutionalized decreased drastically from 154,600 down to 32,900 still in institutions. However, this meant some with severe intellectual or developmental disabilities were taken out of those institutions with no support, and therefore their quality of life actually got worse because they did not have the care they needed. It also meant there were a lot of community living alternatives that were forced to take on these individuals that they didn't have the supports to be able to help them. Wasn't appropriate for them. There was not sufficient funding to support a mass integration of these individuals. Again, they did not have the support services they needed to be able to succeed. There was a lack of social connections when they're segregated, which means that they are more vulnerable to having adverse events, more vulnerable to trauma because they don't have the social support. Segregation also was geographical. So there are a lot of geographical constraints to be able to access support and connections. People who were put in very rural communities that didn't have any of the supports they needed were kind of left on their own. There were a lot of anti-discrimination policies put out there by putting out services. Hey, we have all these services to help you, but if they're not acceptable, they're ineffective. If they can't access them, they can't be effective. A lot of the services that are there are also not adapted to be able to serve this population. The next disparity was society's response to trauma, and this is a response overall, not just the IDDD population, but soldiers coming home that have PTSD, familial violence issues, near-death experiences, panic responses. Society historically has not responded well to any of these things. There's a lack of resources available, a lack of acknowledgement that it's even there. The resources that are considered available, not accessible to everyone. When we're looking at the population that we tend to serve, a lot of that is due to adaptation issues. So they have communication deficits, or the way the services are delivered don't work for this population. Maybe they're unable to get to the resource, either because of a geographical issue or because their trauma responses don't let them leave the house or don't let them function well. Or it could be they just don't know that the resources are there. In general, there's been a lot of negative views of the behaviors that are trauma responses. People have been called weird. They've been told they're just being hysterical or they're abnormal. Sometimes those responses are even criminalized. The third disparity is communication deficits, especially in the intellectual and developmental disabled population. These people tend to communicate differently. That's just this population. That increases their risk and decreases the effect of typical treatments related to trauma. So we've got persons who are nonverbal. We've got some who are verbal, but they have processing deficits. We have some who have expressive language deficits. You may think they're understanding what is being told, but maybe they're not. The limited abilities to report trauma, so even knowing it's there, to be able to communicate that they need something. So therefore, they're going to have difficulty accessing effective services. Just because they're available doesn't mean they're accessible or effective. They might not be able to communicate their basic needs. That increases the risk of being neglected in some way, shape, or form. They're also unable to access typical support options such as groups, therapy, online support, if they don't have the communication needed to be able to participate in these things. The fourth disparity discussed was assessment and treatment deficits. So there are a lot of trauma assessments out there. There really are lots of ways that we can look at it. They are not normed for the IDDD population. They have not been tested on this population to know what works and what doesn't. They're not adapted to allow these assessments to be used with this population. So many of these assessments are based on an interview with the client, a discussion, getting their history directly from them. The population we work with generally can't do that. There's definitely treatment out there for trauma and what they call stress-related disorders, which this article talked about a lot. Stress-related disorders connected with trauma, because a lot of times that's the trigger. Generally, what's recommended is talk therapy. How can a nonverbal individual benefit from that? It's often focused on processing feelings and emotions. If someone has communication deficits for basic communication, they're not going to understand abstract things like talking about their feelings or emotions. And finally, there are very few providers out there that actually have the training to give trauma-related treatment to the IDDD population. Misdiagnosis is a big problem with this population as well. So the behaviors and symptoms related to intellectual and developmental disabilities commonly lead to a misdiagnosis of mental health disorders. Historically, and even today, many are diagnosed with things like psychosis or bipolar, when the symptoms are actually just manifestations of autism or other intellectual or developmental disabilities. These diagnoses then overshadow trauma-related needs and being able to identify the trauma, because now we're just calling it psychosis or we're calling it a manic episode, when that might not be what it is at all. So what do we do about it in the ABA world? How can we advocate? This article talked about that too. First advocacy area is increase the acknowledgement and information sharing related to trauma. So first, acknowledge that it's highly likely that the individuals and families you are working with have some type of trauma experience, whether they realize it or not. We can advocate mandating sharing this as part of care coordination. So when we are talking to other providers, as far as a multidisciplinary approach, that we are actually sharing knowledge of trauma. So if one provider knows that this happened to this family, they should be telling the other provider. Again, that is part of care coordination. That is not violating HIPAA, as long as you are all on that same case and it's related to the care of that individual. It also means we need to be connecting maladaptive behavior to trauma and advocating for that. That the maladaptive behavior itself is not just because this person is mad that they didn't get what they wanted. There might be something more to that we need to look at. Not always, but there might be. Also realize that behaviors might be a signal of a trauma experience. So if something is happening and we're having a new behavior, or it's a behavior we know about, but they're reacting to different signals with that behavior, that lets us know that there might be something there we need to look into. Especially if it's a previously neutral stimuli that has now been paired with trauma, no longer neutral. So if we see that change, we know something has happened. The ABA commitment to realism that we get from Skinner mandates that we recognize that traumatic events exist. They may not spell that in those words, but that's realism. We need to recognize that things have happened. So therefore, the existence of trauma is there. Realize that someone's perception of events can affect their behavioral response. And traumatic events can affect behavior, even if the person didn't receive it as trauma. So that works both ways. A lot of times you'll hear perception is everything. And in some ways, in some areas it is, not with trauma, especially with the IDDD population, because they're not realizing how it affects them. So something may happen and you think it didn't bother that kid at all, and you're like, oh my goodness, how resilient. It may be they didn't recognize that it bothered them, but it comes out in their behavior later. We need to advocate using the tools that are available to identify potential trauma needs. One of the easiest ones to apply in our field would be the ACEs, so the Adverse Childhood Experience Scale. We could also advocate a minimum amount of CEU credits in our field related to the effect of trauma on behavior. Another area that we could advocate for. So that's advocacy number one. Second recommendation was individualizing assessments and adapted services across the lifespan. So one thing you have probably noticed in our field is there's a lot of services for childhood, but when they become adults, there's not nearly as much. A lot of that is because insurances stop covering the services as they become adults. So we can advocate for policies that require these services continue to be covered. We also can advocate training for providers to work with all functioning levels throughout their lifetime. We also can advocate for trauma-informed care in our functional behavior assessments, making that just part of what we do all the time. That means we look at trauma-informed approaches from the get-go with the assessment. That we're going to identify functions of behaviors related to trauma, still in behavior analytic terms, be open to acknowledging that trauma might be part of that, and how does that factor into when we're looking at what the function of the behavior is. Know that those establishing operations and motivating operations might not be immediately apparent, they might be historical. Incorporate reinforcement and punishment history as the information on the assessment. And make sure we are constantly assessing, constantly looking at what is changing, what do we need to do to help support. All right, so this is an example from Advocacy 2. So this is something, could do a screenshot. We can share the slides later. But these are just some generalized from a policy in Texas that a school put in for requirements for improving education for children with autism. So generalizing guidance to multiple settings, which I thought was really neat to share. And they're advocating for additional state funding to help support that. So Advocacy 3 is increasing research and funding to apply trauma-informed care services across the lifespan. So research devoted to this, looking at those assessment needs, adapting assessments to meet the needs of the IDDD population, especially those who have very severe intellectual and developmental disabilities. Even the adaptions that are out there that have tried don't even touch those who have these severe impairments. And make sure that we're prioritizing research to inform effective assessment and treatment from the ABA lens. We're already doing that work. We're just applying it from a trauma-informed perspective. So advocating for policies that require observable and measurable outcomes related to trauma-connected behaviors, showing that we can use trauma-informed care and have it measurable and observable so we can actually get some of that data about whether or not it's effective. And of course, improving our skill building. Any questions? I know that was a lot of information and we're going to go more into it on the 30th too. Thank you. I'm glad you found it interesting and helpful. Right. Yeah, it's definitely a topic that I feel like we need to be addressing more. One thing I've definitely seen a lot of is a division between like ABA and mental health. And as somebody who is trained in both, they overlap so much more than people acknowledge. Yeah, I definitely can post the slides for sure. I'm going to make sure that you guys have the sign out code. So a new website for the CEUs, because they now are QABA CEUs as well. And then there'll be a quiz on there as well for you to be able to get that code or that credit. Yes, definitely a whole person approach. Awesome. And I will hang out for any other questions for a few minutes also. Someone asked, does trauma-informed ABA care also include forms of CBT and ACT? So CBT is therapy. So when I have done counseling in my first life, my first career, CBT was my thing. And it very much overlaps with a lot of ABA as far as the behavioral piece. The cognitive piece, not so much, because that is more the processing. And we're not doing that in ABA. We're not processing trauma. That is not our lane, not our role. Don't do that. But the behavioral piece, there's a lot of overlap. And there is growing research about using the ACT approaches in ABA. That definitely is coming out there more, and it's actually on the list of something that we want to address in the PGP in the future.
The sign-out code for this presentation is 5246.